So please be ready for listening to Dr. Sonia Elrich Sachs, which I invite here to the stage. And please, I would like you to welcome Dr. Sonia, please. You can talk either with that or standing at the podium.
I'd like to be able to.
Okay. Well, Dr. Sonia, she's a physician, she's a pediatrician, she's also endocrinologist, isn't it so? And she will focus on a specific sustainable development goal, which is number 3, which is health. She has experience of working in the tropics and also being the director of the health sector of the Center for Sustainable Development at the Columbia. She has a point of view which is privileged to look at all what is going on for the implementation of SDGs, and in particular SDGs 3 all around the world. Well, I will ask Sonia to speak slowly, not slowly, but as easy as possible so that everybody can understand. And after the talk of Sonia, there will be some time for questions, so be ready also to ask a question. I see some pediatricians here, isn't it, Fabian? He is responsible for our development project, pediatrics sector, Medicus Mundi, Italy. Sonia, the stage is yours.
Thank you so much for allowing me to join you. I'm actually originally, as I told Professor Castelli, I'm originally from the Czech Republic. I was born and raised, and I remember really resenting a lot of the Americans or the British people who would come to Prague and assume that everybody speaks English because that was the lingua franca, Anglica. So here I am now, an ugly American doing, which is I'm imposing on you by speaking in English, and I apologize and thank you for indulging me. I could also discuss this in Czech if anybody would prefer. But yes, I forgot to ask you where I advance the slides. Here? Is this it? Okay, thank you. I first of all very much appreciate Professor Castelli's invitation to both me here now, giving me this privilege of speaking with you, and then my husband, Jeff, later on. I do appreciate it because I really feel passionate about this topic of universal health coverage, which basically means providing the very basic health care to all people, especially in poor countries. And it's very frustrating for me and many of us in the field, such as my colleague, Professor Castelli and others, that it's a subject that we've been talking about since 1948. After all, already the WHO and the UN has declared that health, basic health, is a human right. And so it's been 70 years. It was reiterated in Alma Ata. Those of you who study public health, there was a famous conference in Alma Ata which reinstated this concept that by the year 2000, everybody would have access to basic care. And here we are, 2018, and we're still not there. So it's frustrating, and it's also an opportunity to really focus and make it happen. And I think some of you will be the ones who will be working on it and succeed. Oops, I was just shown how to do it. This map shows why I and many other people, of course, focus mainly on the low-income countries, because there's, as you all know, a huge disparity between the access to health in countries like Italy, the US, and others, and the low-income setting. And for me, this sort of summarizes the incredible disparity, inequality, injustice, unfairness. This is just that shows life expectancy, which is just one indicator, which of course encompasses many things, not just health, but it's a good overall indicator of health, and the life expectancy in the world. And as you get darker, the better life expectancy. So you see that, of course, it's the usual suspect: Canada, US, a lot of the countries in the high-income world really do now, in Japan especially, live up to 89 years of age, whereas there are many countries that, of course, again, mainly in sub-Saharan Africa, which has a lot of disadvantages, historical, ecological, climate-related. There are parts in Africa where the life expectancy is an entire quarter of a century lower, 25 to 30 years lower than what we enjoy in the rich countries. So that, to me, summarizes the disparity. The basic problem is that in spite of a lot of improvements which have started in the last 15 to 20 years with the Millennium Development Goals that many of you may be familiar with, which has really accelerated and focused all of our minds on trying to bridge the gap that map exposes, that in spite of that, this is still the status quo. We still have 5.5 million children in the world, most of them, of course, or all of them almost in a low-income setting, that die under the age of 5. And it's shocking because all of the diseases basically are preventable, and if not preventable, they're treatable, which is why it's a status quo that I find unacceptable, and many others do too. And there's still about 300,000 women who die related to pregnancy, delivery, or postpartum, which of course both of these numbers are much better than 25 years ago, but it's still an unacceptable status quo because, as I keep saying, it is preventable and treatable conditions that lead to this. Mind you, there's 330,000 women who die from pregnancy-related problems, leave a huge wake of problems with them. They leave orphans who are more likely to also die, and so it's a huge problem. I keep forgetting how to do this. Oh, wrong direction. This is just, many of you I'm sure are familiar with this, but the problems that cause disease and deaths in children in low-income setting, and if you don't mind, I will focus mainly on sub-Saharan Africa, only because of my own limitations, although I do travel frequently to Asia, India. We're about to go again tomorrow to India. I focus professionally on sub-Saharan Africa, where the disease and death burden is still the highest. And the reason that this focus on child and maternal mortality is so acute is because, as I mentioned before, the children die of common and preventable diseases. So a big chunk die of diarrhea, which of course is related to sanitation, hygiene. Most of these, or all of these problems are related to poverty, which is a very interesting subject and discussion of its own. But we only have time to focus really on the disease burden in and of itself. So diarrhea, pneumonia, a lot of pneumonia being related to indoor use of cook stoves, malaria, and neonatal disorders, mainly basically birth. So the bulk of the child mortality, again, are things that are no longer a problem in middle-income or rich countries, which tells you that these things are addressable because we no longer see these problems in other parts of the world. Am I going again? Yes. Like the rest of the world, I do better by going backwards than forwards, which is how I feel development has been going. Maternal mortality, likewise, really boils down to a very few common problems. hemorrhage, postpartum hemorrhage, which would be, of course, preventable or treatable if there was proper institutional delivery. Hypertension, eclampsia, which of course is very addressable if there's proper antenatal care. And I should have started with this, which is access to reproductive health so that women don't have unwanted pregnancies and related problems. So both maternal and child problems are well identified and addressable. You may have seen this graph. It's, for me, kind of a shorthand way of making one point, which is from 1990 till now, which is, by the way, the time when the Millennium Development Goals started counting the disease burden. There, in fact, has been a decrease in child mortality. So, in fact, there have been some successes for all sorts of reasons that are also interesting to discuss, but we don't have time. But I just wanted to show you one point, which is that the light blue line is all under 5 mortality, and then is newborn mortality. And there are a couple points I'd like to make. One simple one, which is the child mortality is improving. But if you notice, the newborn mortality, although improving, is improving less rapidly. And that's actually a very important point that I would like to discuss in a little bit because it's important. The child mortality has been relatively successfully improved because of specific interventions that have been elucidated by research scientists such as your own Professor Castelli and others, which is that we now know how to do interventions like against malaria, diarrhea, pneumonia, malnutrition. But all of these are one-off interventions that are really impactful and they work. However, what I'd like to show you in a moment is the newborn mortality requires more than just the application of known interventions. It actually requires a system approach, and that's the remaining challenge, which I'll discuss in a moment. So, those of you who work in public health may be aware of the fact that most of the mortality, both maternal and child mortality, takes place in what we call, or what the nutrition community calls, the first 1,000 days. The first 1,000 days start with conception of the baby, pregnancy, and then the first 2 years of life. So it starts with conception, goes through pregnancy, delivery, and then the first 2 years of life. And the reason this 1,000 days is a good kind of thumbnail thing is because most of the disease and deaths take place during this short period of lifetime. So, I mean, obviously there are deaths of young adults and middle-aged adults, but the ones that we can really impact on, because they're the ones that no longer occur in Italy and the US and elsewhere, the ones we can really impact on take place during this 1,000 days, and that's an opportunity. It means during this short part of the much longer life cycle, we really will impact on well-being, life expectancy, etc. So it is an opportunity, and actually, I'm not sure, hold on one second, please. It's an opportunity, now that we can narrow it down to get this right. What did I do now? Still going backwards, okay. It's actually very interesting picture if you look at it this way, because most of the deaths take place during these short period of life. And actually, if you look at the statistics, most of the death happen not only during these 3 periods, but they actually happen during the first month. If you look at this newborn statistics, maternal mortality, most of it happens during 1 month. So we have an even narrower period of time. And as it turns out, if you look carefully, most of that happens during the first week. Most of that happens actually during the first day. And the majority of child and maternal death take place during or around birth. Basically, it is at the time of birth. So during that 1 hour of birth is when the biggest number of deaths of newborns and mothers take place. So again, a huge opportunity. Get this 1 hour right, and you will make a big difference. The problem is that to get this 1 hour of life, of the lifespan right, you cannot rely on interventions such as we public health practitioners have been practicing, which is campaign-style immunizations, which have made a huge difference. Campaign-style immunization, you know, when the villages once or twice a year get the Red Cross to come in and immunize all the children, or to do a delivery of the oral rehydration packet for diarrhea. All of those things can be done campaign-style or made accessible, you know, during the day, on market days. The problem with this is that you cannot deliver it other than with a proper. You actually need something that's available 24/7, predictably and reliably, and hence the problem. So in order to get that one period of life right, you actually need a health system. You cannot rely on something that you deliver when you happen to be able to, or when a donor happens to come by. So in order to get that right, you of course, first of all, need the women to be properly nourished. You need to have a clinic for antenatal care. Sorry for all these acronyms. It's basically to remind me what to tell you, so ignore what you don't. But you need family planning accessible so that only those women who really want to arrive at that life and death time. You need telephony, you need road, you need ambulance, because you cannot predict when the person will deliver, and so you actually need access. And then at the time of delivery, you need to have a clinic within reach that has what we call basic emergency obstetric care. You need a clinic that is staffed 24/7. Deliveries don't happen between 8 a.m. and 5. 24/7, round the clock, availability of midwife, 2 pair of hands, which is another story, delivery, resuscitation. So you need a functioning clinic that's available 24/7. And then that includes also the work that happens postpartum. You need outreach, you need community health worker, nurses who check the mother and newborn. You need a supply chain for drugs, training, supervision, a referral hospital in case the delivery is complicated by hemorrhage or obstruction. You need immediate reach by telephony and by ambulance to reach a hospital for what we call comprehensive emergency medical delivery for cesarean section. And so, of course, you need training, informatics, management, so the whole health system. The point being, there is no shortcut for the institutional delivery to deliver 2 healthy people, a mother and a child. And so this is why the focus really at this point needs to be on systems. Until now, especially due to donor hesitations, health systems health interventions have been delivered ad hoc and not perfect focus on systems. I'd like to just quickly tell you about a project that my husband Jeff Sachs and I have been working on for now 12 years, and it's actually about to be published in the Lancet Global Health in about 5 or 6 weeks finally. It was called the Millennium Villages Project, and the idea of that, and I was in charge of the health aspect of it, but the project of the Millennium Villages project was to show that you can actually address the extreme poverty of a community by focusing not on one silver bullet. It's not like if you deliver health, the whole community will be better off, but that you actually need health, education, infrastructure, business development, and first and foremost, of course, food security. So we took 10 countries. In each country, we went to the farthest remote rural village areas. We chose about 50,000 people in each area, and for a very carefully costed out investment in food security, health, education, infrastructure, and business development, showed that you can actually reach what then were the Millennium Development Goals, which is basically getting out of extreme poverty by working with the community on these 5 basic pillars. But I only have time to focus on the health system, since I showed you that from my point of view, the only way to make a difference, you actually have to focus now on systems delivery. This is what I mean by a system. So this is a community, let's say, of about 50,000 people, and for me, the sine qua non, or the basic core need, is a clinic that's within walking distance of everybody in that area, in a defined rural area, a clinic that is able to deliver at least the basic delivery, so you need somebody there 24/7, a midwife that can do the delivery. I'm now focusing the last couple of years on one part of the health system which I think is critical, which is the community health workers, so that actually each family has access to the clinic, because as most of you who've been to poor rural areas, often the families really are completely cut off. I have met over my 17 years in this business people who have certainly never seen a doctor, and many of them have never seen a nurse, never seen any sort of clinic personnel. So our health system, the system that we advocate for, is that there is a community health worker who's in charge of 150 households for which they're responsible. If something happens to one of these households, it is the responsibility of the community health worker. And it's another long story that I'd love to tell you, but we're advocating professional community health workers, not volunteers who work when they can or when they have time, but community health workers that are fully paid, not volunteers, fully paid, properly managed, properly outfitted with a backpack that has some of the basic tools of the trade, and a cell phone and a smartphone. And that's actually what I work now 24/7 on. I'll be glad to discuss that if anybody's interested. So every household is connected by a community health worker. Community health workers are managed by a clinic, and the clinic has access to a referral hospital if need be. Therefore, you need a 24/7 ambulance and a telephony to summon the ambulance. And there also has to be real-time data, which due to use of cell phone is now possible. So it is this that I consider a basic core health system of delivery, and we did it for $40 per person per year. So a full health system, all that I just described, including the telephony, including HIV care, for $40 per person per year. But that was because we started our project, a 10-year project, back in 2004. We now recommend that it translates to about $100 per person per year. $100, which is out of reach for most of the countries that I work in, which is a lot of the countries in sub-Saharan Africa. But, it's a very small amount of money. Compare it to what we provide care and an imperfect care in the United States, which is $9,000. But as you know, most of the countries in sub-Saharan Africa, the governments can only afford about $15 to $20 per person. So we advocate for a short-term support of the countries that really profess to do the right thing. In order to be able to provide health care, we advocate for support from external donors. So for $100 per person per year, you really can provide this kind of care, and we got very good results. And would welcome any discussion when that happens. However, one more point, which is that the health system cannot live in a vacuum. You really do need to have livelihoods, and there's no point having a health system if there isn't a proper food source. You need infrastructure, roads, electricity, wash is sanitation and hygiene, and proper education. So the health system needs to live in an ecosystem that also provides the other basics. But my point about the health system is that it's integrated, so it needs to be living within education, addressing education and other forms of community support. It has to be free at point of service. This is a critical point. Many people have studied this. Anytime you levy even a small amount at the clinic or when the community health worker comes to the family, anytime you request for fees, paying at the time, the utilization drops. So service has to be free at the time of need. Financing the health system is a different question, but in terms of utilization, this is critical. There should be a continuum of care, so in other words, that each family does have access to the community health worker, to the clinic, and to the referral hospital, and an ambulance system. Those of you, I think you would remember, there's huge discussion 20 years ago whether you should, especially in HIV, focus on prevention or treatment, which drove me and my husband crazy because, of course, you should do both. But it was purely a question of finances because the donors, decided they were only going to give X amount. So it was, do you want prevention or do you want treatment? When you go to your doctor, does he ask, does he tell you, would you like me to advise you how to prevent that disease, or would you like me to treat the one you have now? So focus needs to be on both. And of course, there is room for campaign-style mass application, like bed nets, like immunization. But again, it shouldn't be either or. I very much believe in the community health worker introducing it, not just us, other people in the US. We're actually working on, even in New York City, right in the shadow of a fancy hospital, we started professional community health worker program, and many other people have too. I'm also firmly believe in real-time data, using the cell phone to provide real-time data, and that's something I'm actually working most of my time now, which is what we call mHealth, which is using smartphone to provide both support for the community health worker to deliver better care, but also to get data, which then gives the manager an idea of what is the disease burden. And we're also working on telemedicine, as are many other people. So that's a health system. This, please don't bother reading this. I just wanted to, I unfortunately was not able to come to the meeting that you just had about the sustainable strategies, but I just want to highlight first of all, I believe that the Sustainable Development Goals is really an incredibly wonderful and important international development, in that all of the 192 have actually agreed on this Sustainable Development Goals, and they've developed them by consensus work. All of the countries have worked on these Sustainable Development Goals that I think the government officials showed you, and they're therefore really something that we should work towards because it really clarifies and makes a great overarching framework. I just want to focus on SDG 3, which is the health goal. And I just want to quickly show you why I think the SDG 3 is really pretty comprehensive and pretty useful. So you don't have to look at what it says, but the first 3 points of the SDG, the Sustainable Development Goal, basically continue the work that we've all been focusing on up till now, the Millennium Development Goals, which are the problems that really burden the low-income countries, and but the job is not finished. So it still focuses on maternal mortality, newborn survival, and the epidemics of AIDS, TB, and malaria, as well as the immunization, preventable diseases, and parasitic diseases, etc. What the SDGs 3, this new set of goals, improves upon is that it adds the non-communicable diseases, NCD, the non-communicable diseases, because until now, in the low-income setting, we focused on the infection, nutrition, and childbirth problems, because those were the ones that no longer exist in high-income countries, so we wanted to help merge the low-income countries with the status quo of the middle and high-income countries. So the focus until now was, even in low-income countries, or especially in low-income countries, was on those 3 points: maternal mortality, newborn mortality, and infectious diseases. But now it's expanded for both rich and poor countries, of course, on non-communicable diseases, neoplasm, cardiovascular, respiratory, substance abuse, which is big in the US. I'm sure you've all heard about the opioid epidemic, traffic accidents, and so it expands to non-communicable diseases. And then my pet peeve, my favorite, is the fact that it also addresses the systems approach, which was not the goal of the Millennium Development Goals. The goal of the Millennium Development Goals was to quickly improve the situation, but now it's finally talking about, again, universal access, financial risk, and also, by the way, pollution-related problems. And then the SDGs, this is not my writing, this is from the SDGs. If you look at the SDG website, on SDG 3, this is what you'll find. It talks about tobacco control, research, and then the all critical financing of how are we going to finance all of this. And also it focuses on recruitment of human resources, health workforce, which is one of the things I'm now working on, which is community health worker, especially in low-income countries. So the SDGs now focus on system delivery, financing, and equity. This is just to summarize what I was saying, which is the SDGs, which is an attempt, our last attempt, and we better get this right. We've been trying for 70 years, and now it's time to really get it done. We have a consensus, universal, 192 countries consensus. The SDGs speak to low-income countries as well as rich countries. It now encompasses all disease categories. It finally talks about system of delivery. Yes, we know how to prevent malaria, but how do you, and we know bed nets work, for instance, but how do you get the bed nets to the communities? And how do you make sure they use them properly? How do you make sure there's a replacement mechanism where the bed net breaks, etc.? System of delivery and continuous sustainable system, addressing the financing, measuring it, and of course what makes it all doable is the fact that there has been a lot of research, there are technologies, and international accountability, which I have a lot to say about, but will spare you. This is pretty much my last point. I forgot, do I have a few more minutes? Yeah, pretty much last point. How do you scale up health systems? You know, we know what it takes, we know the interventions, we know how to keep a child alive, we know how to do the deliveries right. how do you, and we and many other people have done pilots like ours in the Millennium Villages project, but how do you scale it up? And this, believe it or not, has been at fault for a lot of or has been a problem for many decades, which is that usually donors come in, usually the US comes in, and in its usually arrogant way, here's a couple $1 million, now do the right thing, and we'll come in a year and see if you've done the right thing. And you come back in a year, and of course, there are problems. That is not the way to approach public health. The way to approach a public health problem is you first and foremost do the epidemiology. So let's say if you're focusing on Ghana, child survival, you first and foremost have to do your homework, which is to find out what is the mortality, what is the burden of mortality, what do children die of, what are the Ghana Health Service system that's already there, what is the nurses. First and foremost, learn what's the disease problem and what is there to address it. So first you have to know where you're starting, then you decide where you want to go. So goal setting is incredibly important. I learned that because I was a garden variety pediatrician, and if you told me that the child mortality has improved a little bit, I used to be very happy. But then my economist husband would say, yeah, but that's such a small increment, it would take 50 years to get to what you want. So having a goal, where do you want to be, by when, is incredibly important. So find out what your burden of disease is, find out what the status quo of the health system is, make sure you know what your goal is, and then do this process of backcasting, the opposite of forecasting, backcasting. If you want to have a child mortality of under 20 per thousand by the year 2030, which is the goal, what does that mean you have to do today, tomorrow, next year, and work on it that way. And then, of course, we take advantage of all the technical interventions. We now know how to deliver the system approaches, all the different tools, technology, smartphone, telemedicine, rapid diagnostics. You can now do a lot of diagnostic, as you all know, of malaria, of HIV, right there in the household without the family going all the way to the clinic. Use real-time data so that you can tell in real time, not 3 years later, that there was increasing child mortality. It's something you should know week by week, which you can do by using the smartphone. We did that in the Millennium Villages, and it's very empowering. And then, of course, don't do it the old way, which is, the donor-directed, here's a couple millions, now do. You first set up the system, find out how much it would cost, and then get the funding needed. It's something that the donors really have to adopt this approach. I don't have time to tell you, but one of the things that we're working on is in Ghana, we actually are working with the government on a national scale community health worker, this concept of taking the volunteers and actually professionalizing them. So we have been working with Ghana. That started a year and a half ago. They hired 20,000 community health workers. E-health specialists, those are specialists who analyze the data that comes from the smartphones. It's paid by the government. They have a lot of financial gaps that we're helping them with. And we're also trying to get the 20,000 community health workers to have smartphones with the training that comes with it. And we've actually we now have 6,000. Out of the 20,000, 6,000 already have the smartphone with the application, and it's a very interesting story that if you'll have me back in a year, I'll tell you about, or you will find you're right. Okay, really last point, but to me the most important point is don't fall into the trap that garden variety people like me fell into, which is saying, well, it's all too expensive. That's what we've heard from USAID, from DFID, from all donors. Yes, we know what to do, but it's too expensive. And this is what I want to leave you with, which is It's not expensive. It's $100 per person per year, of which the government usually can do some aspect of, but some governments, like some of the really poor governments in Ghana, really cannot, out of the 500, 600, 700 that they have, cannot fund it on their own. And this, I'll show you in a second the important numbers. This is just a reminder how unbelievably small amount of funds from the rich world would finish the job. So let's start with just world poverty gap. And I have this from my in-house economist. And it's not disputed. It's just donors don't like to be shown this, but it's not disputed that the entire poverty gap could be would cost about $400 billion per year from donors. Since our world annual income is 125 trillion, I made it 100 trillion just to make it easier for myself. But in fact, the world income now is 125 trillion. So it's my point is even more powerful because in fact, I've lowered the total income. So to close the poverty gap, that means to do the right thing in health, education, infrastructure, food production, would be 0.4% of our world income. The universal health coverage that I described, which is making sure that every family has access to talking about, plastic surgery, we're talking about what we talked about, dying from diarrhea, dying from pneumonia, dying from unsafe childbirth. Universal health coverage, which would save the 5.9 million children and the 1/3 of a million women, would be $60 billion, which is 0.06% of what the world income is. Ending AIDS epidemic, something we've discussed and I've learned a lot from Professor Castelli, is about $40 billion. Again, a very small fraction. I'm working on something that we call 2 million community health workers. And believe me, I've worked 24/7 on getting this $5 billion, which we're not getting, and it's embarrassingly small numbers, 0.05%. Just to show you, universal secondary education, $40 billion. Climate change is $1 trillion, which is why we're all told it's not doable. I unfortunately missed the speaker before, but $1 trillion is 1%. So given that it's a life and death existential problem, it's really trivial. And then just to put it in context, the world annual military spending is $2 trillion, 2% of the annual. Money in tax havens by a few filthy rich individuals, $30 trillion. Global wealth of the 2,300 billionaires, just of those 2,500 individuals, $7 trillion, et cetera, et cetera. You get my point. The donors and the public officials often say it's not affordable. It is affordable. It's just the fact that we don't make it a priority. So, to leave you alone finally, SDG 3, which is the universal health coverage, making sure that everybody has access to basic health, is absolutely achievable. It's overdue. We've been talking about it since 1948 when the WHO, the World Health Organization, and the UN said that that's the priority. It's overdue. We know the interventions, thanks to a lot of scientific work. We have the tools, the technology, the smartphone, and telemedicine has made all the difference. We now have learned a lot about the system strategy, like the one I showed you in the Millennium Villages. We have the funds, is what I tried to show you before. What we need and we don't have is public policymakers' morality and their will to finally get the job done. So thank you for letting me harangue you.
Thank you very much, Sonia, for this overview. which is a systemic one, not vertical programs, but a systemic approach. And also for the patient, you conveyed your message. And also, well, you should know that Sonia and Jeff, they have traveled overnight to reach Italy. They were in Abu Dhabi yesterday, and this morning they landed in Malpensa. So thank you very much once again, because also without rest, you were able to come and share with us your thoughts. Now we have a few minutes for any kind of comments you would like to make to the presentation of Dr. Sachs. We have a hand raised at the back. Please, Federico. Someone from Ghana, I guess, isn't it? Dennis.
Good morning, I'm Dennis from Ghana. I'm an economist, but then I've worked with Ghana Health Service, so I know most of the things you talk about. I did a research in the northern part of Ghana. That's where most people are very poor. And you would realize that when babies are given birth, they are not really cared by medical staff. They are mostly cared by the traditional birth assistant. And through the program you just mentioned, there's been a lot of training for volunteers. And now, about 5 or 4 years ago, there's been schools for people to train under community health workers. So now the community health workers are not in the towns. That is, they go to the remote places to help with the traditional birth assistants, because most of the times, traditional birth assistants, they help the people to give birth. But then when there is a hemorrhage after birth, that is when the babies go down. So from Ghana, we want to say thank you, and then keep on doing the good work.
If I could just add to that, thank you for your comment. I just want to add to that it's really been an incredibly interesting experience to work with, because I work in 10 countries, but it's been a particular pleasure and interesting experience to work with the Ghana Health Service and with the Ghana government, because albeit relatively resource constraint, it's actually pretty well organized. It was eye-opening for me, by the way, to be there in November and to watch your country's campaign for the president and your country's election at the same time as my adopted country, United States, had a campaign and election at the same time. And talk about corruption and lack of transparency. Ghana's government campaign, and I'd like to know your opinion, and maybe we could talk later, but I felt that it was very impressive compared to what was happening in the US. And this is what, the 5th Democratic turnover. And Ghana Health Service simultaneously, I think, is a well-run, well-organized. I have a feeling that Ghana, what Trump would say, Ghana first.
Ghana first. Emanuele. Aspetta un momento, abbiamo una seconda, poi dopo l'ultima.
Good morning, my name is Emanuele Martelli and I take care of management problems. Congratulations for the presentation, and I have this question. You presented a long-term project, and in your slide you presented an architecture of a system. My question is, who should finance in the long term this interesting project, according to your opinion?
So, I wish my economist colleague were here, but from my understanding is, since we and the WHO also agrees that a health system basically requires about $80 to $100 per person per year. Most countries, I don't remember Ghana specifically, but most sub-Saharan countries in sub-Saharan Africa are between 800 to 1,000 income per year, GDP per year. And so if you are lucky to get the 15% of the revenues that the government is able to collect from taxation. So if you, I think Ghana might be $800, so it collects only about $120 per year per person. And so out of $120, out of the revenues collected, the government has to take care of all of the aspects of governance, health, education, infrastructure, airport, everything. So obviously, $20, you cannot spend $100 on health. So our advocacy is that the countries calculate what they're able to do, with transparency and accountability. And then we're asking for donors to fill the gap for a short term, very carefully monitored, holding them accountable to every penny, but for a couple years to support until such time that the government has enough funding to be able to spend about the $80 per person per year. It's been a relatively easier thing to argue for commodities. So the Gavi, the Global Alliance for Vaccinated Immunization, they have the what I consider the gold standard for a business model, which is that they assess the need for immunizations in a country. They hold the government to task, how much can you pay? And let's say they can pay 20% of what's needed for the immunization. So Gavi comes in with the 80%, but there is incredible strict transparency standards, number one, and number two, has to show the ability, or actually pony up more and more. So 1 year it's 20%, 80% is added on, but then they have to graduate. That's been easier, from my understanding, it's been easier to do for commodities. It's still it's still not at all accepted for systems components. So there is no aid program for human resources, for salaries, which is why I'm so thrilled with Ghana, because the 20,000 new community health workers, which also helps them with unemployment, by the way, are paid by the Ghana government. They paid it out of their Ministry of Labor, Ministry of Employment and Labor Relations, out of their youth employment agency. So the government is actually paying the human resources because nobody in the international community will pay salaries. But now the gaps are some of the commodities, actually. So from a pediatrician's understanding is we need to make sure that the government, first and foremost, ask the government to absolutely put up as much as possible of their own domestic resources, and then get the international community for a couple of years to help with the total.
Thank you very much. Is that a comment? No. A very, very short one, because today, my duties today is to keep time because our schedule.
Very short, as a pediatrician. So if you, I guess that if you improve the child, the delivery, the child mortality during delivery, so the improving of this, actually, it's, so you will have, I guess you expect more neurological problem of the children. Because of preterm, so usually the preterm babies, so if you don't have access to, incubator or all these things, something that I think they don't have, so this is the high mortality. When you improve this, I probably guess that you also will face the problem of neurological disease, yes or not? Do you think about this?
Yeah, no, it's, I haven't specifically thought about that question or looked at the numbers, but it makes sense. On the other hand, the number of babies that die or are born stillborn is such a prevalent, huge number. How it compares. You're saying that because of the institutional deliveries, you can now successfully deliver babies that would otherwise die, but now are born with consequences. No, it's a good question, and I'll I'll look into it. My gut feeling is that the burden of death and stillbirth still probably outweighs, but you're absolutely right. By the way, which I glossed over it, but I very much fighting for at deliveries, there should be 2 pairs of hands, because that 1 minute, the golden minute as it's called, 2 people's lives hang in a balance, and there's usually just a midwife. And the midwife in that 1 minute has to make sure that the woman doesn't hemorrhage to death and that the baby takes its first breath. And so, this golden minute should have at least 2 people in it. And it turns out that just doing the resuscitation on the newborn is quite easy, the basic resuscitation, not the equipment base, but just making sure that the baby takes its first breath is very easy. You could teach it to really anybody. They don't even have to be literate or numerate. And it's the lack of the first breath often that causes all sorts of lack of oxygen. So if the baby survives, it survives with problems. But if you at least do that, which is that you have 2 people at that golden minute, the 1 minute, you slightly decrease the chance of problems. But your question is very good. I will look into it. Thank you for bringing it up.
Thank you very much. The topic could go on and on for hours and days. But as I said to you before, my main duty today is to keep time, because the schedule is really hectic. We have our rector here in the back of the room, so that's the signal that we have to stop now. Do you want to say something, Maurizio? No, that's okay. So also on behalf of the University of Brescia and the UNESCO chair, so thank you very much, Sonia, for being with us. Thank you very much for coming, and for